Systolic extinction training. If you have fibromyalgia or a related condition, you've probably never heard of this, but is that all about to change? In this episode of Wisdom from the Other Side, I speak with one of the world's most decorated research scientists, specializing in finding effective treatment options for fibromyalgia and other chronic conditions. Perhaps some of you recognize the name, Professor Dr. Kati Thieme. So, are we on the cusp of seeing highly effective treatments for the wider global patient community? I loved her story of how she accidentally discovers a treatment during her research. Here's a short snippet.
And then the first patient said, I was sitting here for 8 hours and I feel better. What have you done? Yeah, so, and I thought, I don't know. I really don't know. Yeah, so, and then I thought maybe we had a good talk in the between and maybe we like each other and I don't know. So, but then the second and the third patient said the same. And the third patient said, can I come back? Maybe my brain learns that. So, and this was the beginning of the treatment. So it means actually our intention was completely different. We just wanted to find out what is the response of our brain. Yeah, it was a very theoretical approach actually. Yeah, and in the end, we found a treatment and had to explain what we did. That's funny actually.
Our discussions go right into the core of the illness, the pathogenesis, the mechanism. Is the cause of fibromyalgia really a mystery? Is it really a syndrome? What is the role of autonomic dysfunction in this and other chronic illnesses? We delve into all these things and much more. Professor Thieme and I discuss our concerns around medical research for this group of illnesses, as well as how the role of psychology is misunderstood in the context of healing for what is not a psychological illness, but rather a real neurological dysfunction. This interview gets a bit technical at times, but the insights are fascinating, and those of you in my program will probably have a giggle when you see how similar Kati and my views are. She even uses many phrases and terms you regularly hear me use. I must admit, it was a little weird for me hearing how closely Kati echoes my message, but it was very refreshing. What I really loved about this interview is the in-depth research and understanding she has. There's so much to learn from her. Those of you in the ANS Rewire program take particular note when Kati discusses the neuromuscular dysfunctions as well as the interaction with partners during the recovery process. This will hopefully put the physiological and psychological brain training strategies into an even sharper context for you. I could have spoken with Kati all day long. Her insights and research are absolutely amazing. I hope you enjoy my conversation with this rock star of fibromyalgia research. If you have any specific questions from the interview, post them and I will consider them if we do a follow-up interview. I hope you enjoy what I found to be a fascinating discussion. Just a short but important message regarding the content of this podcast. The ideas, concepts and opinions expressed in this recording, website and associated media and products are intended to be used for educational and information purposes only. Nothing presented is intended to replace your physician, nor are they a substitute for medical diagnosis, advice or treatment. This podcast is provided with the understanding that the authors, guests, speakers and publishers are not rendering medical advice of any kind. Hi Kati, thanks for coming to join us on Wisdom from the Other Side.
Yeah, thank you very much for your invitation. It's a pleasure for me to talk. Yeah.
Well, I have been connected with you guys and looked at your research for some years now. Mm-hmm. And today we will obviously focus on your work on systolic extinction training. And of course, most of our listeners won't know what that is, and we will go into some detail. But before we do, I wanted to ask you, you've been a medical researcher for many years now. You've been highly decorated. I know you won the International Fibromyalgia Research Award in 2008. You've won many national awards in Germany. And so your work has been on chronic pain, but at some stage you started to focus on fibromyalgia. And I wonder, why is that?
Fibromyalgia is a very interesting disease for me, because it shows us how stress can influence our body and can change so-called inhibition processes in our body that leads from actually a healthy, very active state to a diseased state. Yeah, so with a high level of impairment, interference, sometimes low activity, sometimes extremely high activity, because the people don't feel the pain so much when they are in a stress situation. And it has so many different phases. It's a very interesting disease, and I like the people.
Well, and it is complex, isn't it? And I think that's probably part of the reason why the wider research community, the medical community, have struggled with this illness, because not only is it complex, but the patient community is heterogeneous, right? It's not that everybody is the same. And, just before we started, you did mention that there was an interesting difference between the patient groups around the world, specifically in America, how people are trying to get away from the word fibromyalgia syndrome. Can you sort of recount to us what that was all about?
Yeah, I observed a very interesting discussion between the patient self-help group or self-support group in US and in Germany. And in US, it is so that the patients say that is fibromyalgia and not the fibromyalgia syndrome, because the syndrome is always something where symptoms are not connected with each other, right? So, and in Germany, the patients say, okay, it's fibromyalgia syndrome. Yeah. I'm actually thinking, when you see the global or the central symptoms of fibromyalgia, like sleep deficits, pain, fatigue, and essential impairments like cognitive concentration and memory deficits, they are connected. Yeah, they are actually clearly connected. Yeah, and maybe we can talk later about this connection also.
Absolutely, and I think this is really what connected us in the very first place some years ago. And really, the thing too is like, I mean, one of the things I often see patients saying is, "How can I be so unlucky? First I have irritable bowel syndrome, and I have chronic fatigue, and then I have fibromyalgia, and then I have POTS, and then I have it goes on and on and on. They feel they've got so many different diseases. But absolutely, you can see that when you really look at it, there is this underlying connection between all of them. And I think when people can understand that, it takes a lot of the stress and worry away, don't you think?
Yeah.
Have you found that with your patient education that this becomes a very important part of their journey, is that they start to understand what's going on, that it helps them feel more at ease and more relaxed?
Yeah, because it's always the case that this kind of complexity of symptoms makes the people crazy. Yeah, they think they are not normal anymore. They doubt in their own perception. Yeah, it must be a very difficult situation. So, and when they learn that all these symptoms belong together and have a clear connection. Yeah, so we start, for example, in patient education with a very easy question. I am asking, what do you think when you hear that word pain? Yeah, then they start with brainstorming what they think about this. Maybe, the pain is something that is disturbing. It interferes my daily activity. I try to lay down, or I'm thinking that is so bad. Why I have this disease? What have I done? Yeah. So, or it's just this kind of sensory description how the pain feels. So, and then I sort all these different answers, and then we see 4 folders, like 4 phone calls. Yeah. So, and each folder is clearly connected to brain areas. Yeah, all the sensory impressions that the pain gives us is connected to the somatosensory cortex, right? So, and all the thoughts are connected to the prefrontal cortex. The emotions, if I feel sad or helpless or sometimes angry, is connected to the amygdala or to other centers of our emotions in the brain. So and then we found out that we have also something else that is actually now in the discussion in the pain field, if that belongs to the pain network, and this is the brainstem. Yeah, and the brainstem is influenced with some components to the autonomic nervous system.
Yeah. Obviously, one of the great battles that many patients face is they have all these weird symptoms. Now, some symptoms can be easily measured, like if they have hypothyroidism or they have abnormal cortisol rhythms, when they do sleep studies, all these type of things. But a lot of the time, a standard blood test is not going to necessarily show anything. And people get, it's suggested like they're just depressed or it's in their head, there's nothing wrong with them, and this type of thing. And so I find it very interesting that, your background is actually in psychology, and yet you make a very strong and clear argument that this illness is not psychological. And I love how that really bridges the gap between the mind and the nervous system, because it seems people always look at these things as being separate.
Yeah.
But obviously the mind, the nervous system, and the body, these are all connected,
yeah,
right?
Yeah, of course. So my argument belongs to this insight that psychological disorders like mood disorders or anxiety are learned disorders, right? So learned by cognitions, maybe provoked by external situations, yeah, or learned by influences by parenting, for example. Yeah, so and here in fibromyalgia, is it more a biological learning? Yeah, so maybe I can tell you a little bit more about this, how it works.
Yes.
Yeah, so for example,
absolutely,
patient is in a stressful situation for a longer time. Yeah, I remember a patient. She was the boss of 2,000 people in a warehouse. Yeah. So, and she, from her personality, is a person who tried to be cooperative with all the colleagues. Yeah, and had trouble when some people responded with aggression, for example. Yeah. So it means it's a lovely lady, actually. Yeah. So, and she did a great job. But sometimes other people can be pretty aggressive and can provoke stress in our life, right? So, and she tried to be more friendly, tried to explain to people why they have to work on this and this way, and so on. So whatever. And she came in a situation that was very stressful for herself. And in the situation turned out that husband said to her, please stop working there, change your job. Yeah. So she doesn't want that because she didn't want to lose this fight also, right? So it's completely understandable. So what was going on in her body? She was in a very stressful situation. Her blood pressure went up, and the blood pressure learned not to vary anymore because she was not able to be relaxed because it was always in her head, right? This is a very complicated situation. And because the blood pressure couldn't vary anymore, the pressure intensities in the carotids developed to be very stable. This sounds actually not too bad, but it's fatal, yeah, for our body, because we have baroreceptors in the carotids, and these baroreceptors work only when the blood pressure intensities vary. Because as soon the blood pressure intensity goes up, so that means the pressure intensities in the carotids go up, then the baroreceptors relay to the brainstem the information, something is going on in the body, please regulate. Yeah. So, and when our pressure intensities don't vary anymore, then the baroreceptors don't relay the information to the brainstem. So it means the brainstem or the brain doesn't know what's going on in the body and doesn't regulate. Yeah. So, and we have a very little nucleus in the brainstem. The abbreviation is NTS, and this NTS has a function to regulate pain, blood pressure, sleep, catecholamines as stress hormones, anxiety, and even blood sugar. Yeah. So, and this nucleus is also connected to different areas of the pain network. So it means when the brainstem doesn't regulate, our amygdala, that is responsible for our emotions, cannot regulate because it just doesn't get the information. Yeah. And so we saw in our EEG tests and examinations that when a patient, a fibromyalgia patient, get a pain stimulus, the response from the brainstem and the somatosensory cortex is much, much later and lower than in healthy people. Yeah. So and normally is it so that it's in the very first 50 and 100 and 150 milliseconds, the brain gets the information, oh, there's a pain stimulus, right? So, and later in about 260 and 400 milliseconds, our emotions and our cognitions respond, right? So, and so we saw in this EEG profile that the somatosensory cortex and the brainstem doesn't realize what's going on, but just in the consequence, the emotions and the thoughts were extremely active. Yeah. And so it explains why our fibromyalgia patients have these kind of doubts, sometimes anxiety and depressive mood or affective distress at least. Yeah. And also these kind of catastrophizings. Yeah. So, and it explains also that we have many, many opportunities to break through this circulus viciosus, yeah, this devil circle, and have many opportunities to influence the pain.
Fascinating. Thank you for detailing that. You talk about the blood pressure variation that the baroreceptors sense. Now, obviously, there's a blood pressure variation, I guess, with every heartbeat, right?
Yeah.
So when you're talking about variation, I mean, that variation is still there. So can you sort of explain how it varies then with people as they get into this stressed state?
Yeah.
Are you saying that the difference is just smaller between the systolic and diastolic, or what exactly do you mean?
Actually, when the people comes in a stress situation, the systolic blood pressure went up, right? Not so much the diastolic, actually, the systolic blood pressure, right? So, and when the patient comes back in a relaxation, then the blood pressure goes down, yeah? And only when a patient is for a long time in a stress situation, also the diastolic blood pressure learns to go up. Yeah, that's why the cardiologists say always when the diastolic blood pressure is higher, then the heart has learned not to be relaxed anymore. It just lose the ability for relaxation. Yeah. In
And so when you say that there is less variation in the blood pressure, do you mean the change in blood pressure in relation to stimulus? Like if somebody is getting stimulated through stress or pain, that it doesn't change as much? Is that what you mean?
Yeah, exactly. So it's a situation that the healthy body is adaptive to the situation. So it means when you are in a stress situation, your blood pressure goes up, and now the stress situation is over, and you can relax. Yeah, we see that very impressively in kids, right? So they are active the whole time. And we as adults are a little bit stressed out. So, and then they sit down for, I don't know, 5 minutes, and we hope, oh, now she's tired. Oh, nice. So, but just, has a time of 5 minutes, and then she's active again. Yeah. So, and this is the best example when we can see, here this people is in a situation, it can be relaxed. So, in this relaxation state, she can consume energy and, or he can consume energy and is very active afterwards. Yeah. So, and when our body is not able anymore to go in this deep relaxation, yeah. So, for example, when our sleep is disturbed, yeah, then this variation that the blood pressure goes down during the relaxation situation is not possible anymore. Yeah.
Well, it's interesting. I can't help but reflect. Now, obviously, your patient group that you focus on is fibromyalgia, whereas I focus on all the different patient groups, including chronic fatigue syndrome, which I consider to be, in essence, the same illness. And when you look at the heart rate variability, it again shows that there is a low heart rate variability, which suggests an inability of. Now, I know a lot of people are suggesting it. That means, that it's in the sympathetic response. But I think a better way, from my point of view, is to say it is not able to express a parasympathetic response, which is exactly kind of what you're saying here, isn't it? Is the body just can't quite come down.
Yeah, it's completely right. So we have two terms. We have the variability of the heart rate, and we have the variability of the blood pressure. And this heart rate variability has much more intense research than the blood pressure variability, right? So, and we learn from the heart rate variability that exactly this problematic of the disbalance of sympathetic and parasympathetic nervous system can create a disease, a disorder, yeah? And we see this mechanism in many, many chronic diseases, yeah? And when you come back to the NTS, yeah, then you see that all the global diseases like hypertension, chronic pain, sleep disorders, diabetes, anxiety disorders, yeah, all these global diseases have actually the begin in this dysregulation of the NTS and the baroreceptors. Yeah.
I'd like to just sort of go back a few steps. We were talking about how we have this lack of variability in blood pressure, or lack of responsiveness, let's say, and how that obviously impacts via the baroreceptors to the NTS, and then it goes to the rest of the network in the brain. And you drew the conclusion from that, how that timing of the blood pressure sensing translates into a delay in the pain sensing. Can you sort of talk a little bit, because most people will listen will say, well, here we're talking about blood pressure, now we're talking about pain. How do they come to overlap? How does that connection happen?
Yeah, actually, in healthy people or beings, even also in animals, we have an inverse relationship, of blood pressure and pain. So it means maybe our patients can remember before they develop the pain disorder, when they have perceived an acute pain like a headache or teeth, So and then the normal situation is that we think, oh no, I don't want that. I don't need that. So it means so this kind of catastrophizing is coming up as first, probably, yeah, and also the emotions. Oh no, this is not nice. Yeah, so it's just a little bit anxiety or anger, and maybe also a little bit depression. So and then at the same time, in a high subgroup of us, yeah, so more than 50%, the blood pressure goes up, yeah. And as soon as the blood pressure goes up, the baroreceptors are activated, right? Because the intensity, the pressure intensity is going up, and so the baroreceptors are awake, and they send the signal to the brain stem. The brain stem regulates, and the blood pressure goes down, and the pain. Yeah, so it means the pain goes up, and then the blood pressure goes up, and the pain goes down. And this is this kind of inverse relationship in healthy beings, yeah, people and animals. And as soon we come in the situations that we have for long-term stress in our lives, and we develop the risk that the pressure intensities go up. Yeah.
So you mentioned obviously that there is this variation in how people's body responds in healthy population or in the fibromyalgia population. And I know you did some research looking specifically at the autonomic nervous system dysfunction that people have with fibromyalgia, and you found that it goes into different subgroups, right?
Yeah.
And I wonder, how can we work this out? How can we have the same issue with the barosensitivity reducing and creating pain, even if we don't have high blood pressure? Because some people have low blood pressure, right?
Yeah. So we made a stress experiment, and the stress experiment had two stressors. One stressor is a mental arithmetic, and one stressor was a social stressor. So we asked the patients before the experiment related to their partnership. What are the problems that you discuss with your partner, and what are the problems that you don't discuss with your partner? So, and then during the experiment, where we have invited the partner too, yeah, we ask both, what is the reason that you don't discuss this topic anymore? Yeah. So, and this was an extremely high stressor for all of our patients, because it was so, actually I could have
confronting,
bring a lion in the room, yeah. So and this was an inappropriate stressor, because we couldn't find any differences between our patients anymore. It was just too much, yeah. So an experience that social stress is really this what makes us sick, yeah. So and mental arithmetic as a performance stressor allowed to find the differences between the patients, and we found 4 different responses. Interestingly, the same responses that we found years before with patients with rheumatoid arthritis and systemic lupus erythematosus as inflammatory rheumatic diseases, patients with hypertension, patients with chronic depression, so more psychiatric disorders, and also in healthy people. Yeah, we have tested astronauts and cosmonauts, so very healthy people. And so it seems these 4 different response patterns are pretty valid in our human responses. Yeah. So, and the most important or the major stress response was the response with high blood pressure, followed by the response with low blood pressure. So, and here we differ between baseline and reactivity, and we see that people can respond with a high blood pressure in the baseline. These are clearly our hypertensive patients, and they can also respond with normotensive blood pressure. But as soon as they come in a stress situation, they go up and respond with hypertensive blood pressure responses. Yeah. So, and in the second group that you mentioned before, is it so that people can have a hypotensive blood pressure as the baseline, and also a normotensive, but can go down, yeah, in stress situation, yeah. So, and
Right, yes.
And the interesting thing is, it provokes also this kind of stable pressure intensity in the carotids, and that reduces also the baroreceptors. Yeah. So, or reduce the activity of the baroreceptors. Yeah. Fortunately, we can always awake them. Yeah. But as soon as the people is in a stress situation, the procedure is the same. The baroreceptors just sleep. Yeah. They don't work anymore.
That's very interesting. Often, we see that we have in this. If we look at the patient population a little bit more broadly than fibromyalgia, and we see the especially the category who starts to get the low blood pressure, and obviously less variability, but they don't necessarily develop the pain syndrome, and yet they still get all the other things that are part of the illness except the pain.
Yeah.
And I sort of wonder what they get the fatigue, or they get the tachycardia attacks, they get the anxiety that can come on all through the NTS, that same network, except the pain doesn't seem to come on. And I wonder, why is it that with them the pain doesn't become so prominent, even though they still have this lack of variability in their blood pressure?
Yeah, we see an interesting phenomena, and we call that stress analgesia. Yeah, and here is also again this kind of very interesting close relationship between psychosocial adaptation and between biological learning. Yeah, and so for example, Dennis Turk found out years ago that we can respond in 3 different psychosocial adaptation types, and one type is a so-called interpersonal distress type, and that means the people, the patients mention that the partner doesn't respond so positively to their disease, mostly negatively or even with punishment. So like that they don't respond when the patient is in trouble with the disease, or that they don't support, or that they don't say any nice thing. They are mostly stressed out. We found that these partners mostly suffer by themselves with with mood disorders. Yeah. And that's why they are not able to respond with empathy. Yeah. So, but that leads to the situation that the patients, the fibromyalgia or fatigue patient, thinks, I shouldn't show so much that I'm in pain. So, and to avoid this kind of negative responses, they start to be more active that they can tolerate, actually. Yeah. So, and that provokes new stress. And interestingly, these patients have a very high activity of the so-called mu opioid receptors. Yeah. And these mu opioid receptors provoke the stress analgesia. So that means, in contrast to other patients with the same disease, if fatigue or if fibromyalgia, they don't perceive so much pain, or to be correct, they perceive less pain as soon as they are in stress situations. And so they experience the stress situation as well-being, because they don't perceive so much pain, or they perceive less pain, actually. So and this perception of feeling better as soon as they are in a stress situation is a huge reinforcer, for our brain. It's like a reward. Yeah, well-being is always the strongest reinforcer. It's a reward for us, right? So and so they come automatically. This has nothing to do with our conscious mind. It's just an unconscious, we call it operant conditioning learning. And as soon you are in this situation, you try to come back in this kind of well-being situation. Yeah, and this explains why this subgroup of our patients are so active, so extremely active. Yeah, I remember a patient, young lady, and she said, actually, I don't know if pain is my first problem. I feel more fatigued. Yeah. So, and this is, I'm not so strong anymore, and I don't know why. And I was aware that something is wrong, probably in the evaluation of her own strongness, and I doubted this by I don't know any reasons. And I'd ask her, tell me a little bit. What is that? What you do over the week, right? So, and then she told me that she has two kids. One of the kid is mentally retarded. This other kid is highly gifted. Both kids need a lot of special support, yeah, for their mental, how can I say that, needs, yeah. And then they build a house. She has her father-in-law at home, and the father-in-law has an Alzheimer, so it means they have pretty often visits from the police because he's running away and they have to look for him. Yeah. Then her own mother has a dementia, and she has the mother in a senior how can I say that, hospital, or what is the right term? Yeah. So but she tries to visit her 3 times a week because she doesn't want that the mother forgets her, right? So, and she is working full time, and her husband too, and this is a moment when I was thinking, oh, wow, I couldn't handle this. Yeah.
Well, I mean, if we took her and made her somebody who was a bomb diffuser in the Middle Eastern war zone, she would probably experience a stress reduction improvement in the symptoms, right? Okay, look, so...
Oh, and one point, just a second, and one point is essential. When she would leave all these kind of tasks to fulfill, she wouldn't be able anymore to relax. Yeah, because she is so adapted in this situation that she would feel guilty when she would say, no, I can't do that anymore. Yeah.
Relaxing is a complicated thing, and it's not an easy thing. And in my experience with seeing people recover from fibromyalgia, CFS, and POTS, I would say that the number one thing that stops them is their inability to just back off and show themselves some kindness and give themselves a break.
Yeah.
And it's quite surprising because in chronic fatigue syndrome, people make a strong connection to post-exertional malaise. So everyone knows, hey, if I do too much, I become sick. And yet our ability to not do too much, it's very, very difficult for people. And they keep getting caught and they don't progress in their recovery because of this. Yeah. And so I wonder, why is it that people have this, find it almost impossible to just stop and give themselves this time to heal and recover? What do you think it drives them?
Yeah, I think this is an automatic process, right? So it means when they, for example, when we take the second subgroup, with the hypotension, but actually we can do almost the same with the hypertension. Then you see they experience when they do more, they have less pain. So just what is the consequence? They do more. Yeah. So in the hypertension group, is it so when they do less, they have less pain for that moment, right? So and then they do less. So the body learns in one group to do less, and in this other group to do more. Yeah. But both leads to the situation that they do not have so much physical tolerance anymore. Yeah, they cannot tolerate additional tasks. Yeah, by different ways, of course. Yeah. So, and what we said before, the consequence is that the variability is not given anymore. So that means the brainstem doesn't know actually what's going on in the body. And when the NTS doesn't regulate anymore, how should the body be able to be relaxed? This is not possible. Yeah.
So really if I can paraphrase you, what you're saying is in one group we're doing too much and therefore we can never gain rest, and the other one we're not doing enough and so we become deconditioned. But both of them lead to a reduction in ability to do things, right? And obviously the nervous system that's supposed to regulate our ability to respond to stresses, if that doesn't go up and down, that kind of reflects that, doesn't it? Because it's supposed to be rest and digest. We're supposed to come down so that we recuperate and then we can do things again. But with the baroreceptor NTS pathway being sort of, I don't want to say flatlining because that sounds too negative, but let's say not very variable, there's no power of rejuvenation
actually,
in the body.
Then this is not wrong. I mean, when we made our first test with the baroreceptor reflex sensitivity, we saw, this was in North Carolina, in 50% of our fibromyalgia patients, no baroreflex anymore. Completely flat. In the first point, we thought, wow, our technique has damage.
It's broken.
Yeah, it's broken.
You need to get the new equipment. Where's your engineer?
Oh my gosh. So, and then we consider the group of healthy people, and here everything works. Everything was fine.
Yes.
Yeah.
Okay, so in a moment we're going to start talking about reversing this. And obviously the brain is plastic. We can go one way. The brain can learn to do these silly, unhelpful things. And the brain can learn to function more normally again. And obviously that's your focus, neuroplasticity and normalizing. But before we talk about this mechanism, I just need to ask this. I said this, I think, before we started. When I wrote my book and I came up with the hypothesis, and I now describe this as reinventing the wheel, right? But everywhere we looked, it was still said that the cause of fibromyalgia or the mechanism is a mystery. And I remember at the time reaching out to some pain researchers and saying, hey, have a look. I think ANS is a central component of this central nervous system dysfunction and this pain sensitization. And I got kind of a very skeptical response. Yet it appears to me that there's a lot of evidence for this, clear evidence that this is what's going on. I mean, what would you say is the most, one question in two parts. One, what is the most compelling evidence about this? And two, do you think that the research community is moving towards a consensus and recognize that this is what's going on?
Yeah, I think, these responses that you have gotten is probably related to that what we call the medical history mystery. So it means in the first place, the people had to learn, or we had to learn, that pain perception belongs actually to the central responses, right? This is our brain. So it means we made the experience independent on the level of damage. We can feel different pain. Yeah. So the next step is now to see what is the influence of the autonomic nervous system and what is the relationship with the central system. So it means we have a lot of researchers and physicians and also psychologists and physiotherapists who have to deal with this idea that brain is not one-to-one related to the level of damage. Yeah. I mean, when you consider all these kind of not so useful surgeries, right? Back pain, for example. Yeah. So it means this is a really a clear topic. So and then the next thing, this experience what we had with the fatigue syndrome or with the fibromyalgia, it's not a psychiatric disorder. Yeah. So it means this neuroscience insights helped us, to convince patients and professionals that it's not a psychiatric disorder, and the damage is not responsible for the intensity of the perceived pain. Yeah. So, and now the second thing is to find out what are the relationships to the autonomic nervous system, right? And this disturbed or diminished inverse relationship of blood pressure and pain, that was actually described in 1994 in the NPAS, so in a very high-ranked journal by colleagues from Tübingen, together with Berit Dworkin, who worked in the Karolinska Institute right now. These colleagues described it very intensively, this kind of diminished inverse relationship of blood pressure and pain. But normally, insights need at least 50 years until many people see that, or recognize what's going on. And the thing is, because no money was given to the research for clinical trials at this time, so in the 90s, they just described that for healthy people, and they mentioned that in people with chronic disorders have a diminished inverse relationship, but only right now is it so that we are working on it, that this diminished inverse relationship is actually kind of an how can I say that? So a clear suggestion of the relationship of autonomic nervous system and the essential nervous system. But it's hard to believe for many people. And of course, we have this kind of impressive heterogeneity. So it means here the research has a task to select the people. Right now we have, from the methodological point of view, this idea that the RCT studies, the randomized clinical trial, so it means randomized, not selected, has a higher standard, right? But on the other hand, we have the idea that the individualized treatment, has the highest chance to heal, or to make our patients feel better. So it means we have here different approaches that fight with each other.
Look, absolutely, and this is one of the points I keep making is this idea of how do you do a clinical trial when the treatment is supposed to be different for the people in it. I mean, this doesn't make sense, right?
Absolutely.
And the other thing is that my concern is with these kind of studies, and I've had a look at setting up a study for ANS Rewire is, well, how do you then measure it, and what do the outcomes mean? Because people will then often draw conclusions, and in medicines, people often talk about responders, non-responders, and partial responders. But if I were to get a proper scientific study of, let's say, a sample of 100 people or 1,000 people, and I would say, okay, well, these people responded great, partial and non-responders, but that does not necessarily reflect the approach. It you've got to really ask the question of why did those people not respond, as opposed to saying it simply doesn't work for them. Because I think at the end of the day, it's still the same disease, even though we see these differences, right? So, and obviously somebody who's got a history of PTSD and a person who has diabetes or hypertension leading before they had fibromyalgia, you need a different treatment, right?
Of course. And of course, you need also a different approach regarding the medication, right? So it means we have a lot of medication who provoke the diminished relationship between blood pressure and pain, who provoke these kind of diminished baroreflex sensitivity.
So are you talking about beta blockers and things like this?
So non-selective.
Is there any? Is there any other sort of medications that do this? Or
we saw in the psychiatric field, for example, anxiolytica or antidepressants, or even medications that are used for treating hyperthyroidosis. Yeah. Some neurological.
Hyper or hypo? So hypothyroidism or hypo, like high thyroid or low thyroid?
I guess it's a high. No, it's a low. Sorry,
High thyroid.
it's a low. Yeah. I have to think about our patients right now. Sorry. Yeah.
Okay.
Yeah.
Right. Interesting.
So
interesting.
And of course, you don't know which patient is responding with the reduction of baroreflex sensitivity when they get these medications. Not everybody is responding on this way. Yeah.
So I think it's natural for us to talk now about affecting positive neuroplasticity, right? Okay, the brain loses its way. We end up in this state of dysfunction, and we talk about reversing it. And I guess this is where, in your research, you started to work on systolic extension training. Yeah. And in a moment, I'll get you to explain what systolic extension training is. But I have to tell you, part of me went that, how did I come up with this?
Yeah, I mean, this was this was actually an interesting experience when I worked in North Carolina with Rick Gracely and Bill Maxner. We actually wanted to find out what is the meaning of the baroreflex sensitivity for the fibromyalgia patients, right? So, and we knew from earlier studies that always when we give stimuli after the systolic peak, we will reactivate the baroreflex sensitivity. So, and we were thinking, okay, we have to check that again. We have to test this, and the best control condition is when we give the stimuli also after the diastolic peak. Yeah, as a control condition, right? So, and then we wanted to find out if it's really true that the central response is different when the stimulus comes immediately after the systolic peak or after the diastolic peak. So we made an EEG experiment. And then we thought we should test also if it makes a difference if the patient gets pain-free stimulus or a pain stimulus. So in own early studies, we saw that our brain doesn't learn when the brain gets or the body gets a stimulus that is 50% of our tolerance, of our pain tolerance. But it learns when it's 75% or even 100% of our pain tolerance. Yeah. So 100% was not allowed because of ethical reasons. So we selected 50% and 75%. Yeah. And in comparison to a pain-free stimulus. Yeah. So in these three types, they're given immediately after the systolic or after the diastolic peak. So, and we made this, and then the first patient said, I was sitting here for 8 hours and I feel better. What have you done? Yeah. So, and I thought, I don't know. I really don't know. Yeah. So, and then I thought maybe we had a good talk in the between and maybe we like each other and I don't know. So, but then the second and the third patient said the same. And the third patient said, can I come back? Maybe my brain learns that. So, and this was the beginning of the treatment. So it means actually our intention was completely different. We just wanted to find out what is the response of our brain. Yeah, it was a very theoretical approach actually. Yeah, and in the end, we found a treatment and had to explain what we did. That's funny actually.
So, did you find that both groups responded, like with the stimulus after systolic and with the two different groups, one after systolic, one after diastolic?
No, we saw that from the central responses, the brain responds only after the systolic peak. Yeah, but the interesting thing is when we give only stimuli after the systolic peak, the brain adapts and cannot learn anymore. Yeah. So when we give it also, when we bring the brain in a situation that the brain gets also stimuli after the diastolic peak, what doesn't provoke the reflex, yeah, then the brain has really to learn.
Interesting. So is it?
It's like an interval
when
training, in the gym.
Yes. Yeah. I see what you mean. But so is the idea that when you give the pain stimulus at the systolic, is it that it creates a higher peak? Does the pain create an increase in the blood pressure in that moment, and is that why we are getting this baroreflex sensitivity?
Yeah, and it's of course probably more mechanical thing. I mean, the systolic means the blood goes from the heart directly in the carotids, right? So the diastolic means it goes in the body. Yeah. So and when the blood goes directly in the carotids and we give the stimulus, at this moment the pressure intensities are changed in the carotids.
Fascinating. So you're talking about the that it works at higher thresholds. Is that because? Do you think it is because there's a bigger increase in the blood pressure, or could it be because it creates a greater level of focus in the brain? Because neuroplasticity, focus is really one of the main factors to affect positive neuroplasticity, right? And nothing like getting really good focus as getting a bit of a zap.
We are in the beginning with these questions. The only thing what I can say is that when we give the stimulus after the systolic, we provoke this baroreflex, a reflex, right? A biological reflex in the brain. So when we give it after the diastolic peak, we don't do that. So it means this is just this kind of life condition what the patient experiences, unfortunately, every day when he or she gets pain. Yeah.
Obviously, this was a surprise, and research is like that, isn't it? We do things and we discover things that sometimes we don't expect. Did you have many other moments during your years of fibromyalgia research where you stumbled across something and go, wow, I didn't expect this?
I mean, I think it's so that this kind of intuition probably works after you have worked in different fields in the research that leads to exactly this result, right? Yeah.
Did you ever have any other sort of moments where you were just surprised at what you found doing your user research, where you just went, wow, I really didn't expect that to occur? Did you have many moments
this
like
is
that?
mostly the case in the treatment. Yeah. With many of these moments. And when, so for example, we have started also to treat patients with opioid addiction, right? So, and we saw when we give them the stimulation twice a week, additionally to the psychological pain treatment, it didn't help. Yeah. So, and the patients told us, when I get the stimulation, so within 3 hours, I feel much better. And then 6 hours later, I feel so worse. So, and we were thinking about this and tried to find out what is the reason for that. And then our hypothesis was maybe it's because the brain hasn't learned that. Yeah. And hasn't learned means maybe this kind of opioid and endogenous opioid and cannabinoid system has started to work and then it crashed. Yeah. So it means they need more, just more. Yeah. And so we started to give them the stimulation every day. And in the first patients, we had to find out for for what kind of time. Yeah. And the patient reported after 12 days, so 12 stimulation, they are free from the opioid addiction. Yeah. This was also a very important moment, because usually I learned we need at least 12 weeks. We have to reduce the doses of the opioids, so that the patient doesn't know about this, and have to be focused on distraction and well-being and so on, and the patient shouldn't make so many pain protocols so that he isn't focused on it, or she, So, and here we had 12 days, and now we have, developed this treatment that we say, okay, we make 12 days every day, also over the weekend. And then, we start with this kind of 3 times a week and later 2 times. And so we saw even in patients with neuropathic pain because of, the paraplegic disorder. Yeah.
Mm-hmm.
Right. Yeah.
Paraplegic.
They have this kind of neuropathic pain as a phantom pain. Yeah. So it means in these areas of the body that are actually paralyzed. Yeah. So, and they have a huge amount of medication, and so we could see that they could reduce medication to 75 to 80%. Yeah. And could reduce their pain to the amount to the intensity of the numeric grading scale 1 and 2. Yeah. So, and anesthesiologists start only with medication when they have more than 3. Yeah.
Yes.
So it means in contrast to the fibromyalgia patient, they don't lose the pain, but it's so low that they don't need these kind of very intense medication anymore. Yeah.
Because opioid medications don't necessarily work on all fibromyalgia patients, right?
No, so opioids.
In fact,
no.
In fact, would it be fair to say they don't work on most fibromyalgia patients? Can we go that far?
I have problems to give these kind of global conclusions. I really like to see the patient, and I have a low number of patients who is helpful the opioids or the cannabinoids. It's a very low number. I can remember, to be honest, only in 2 patients. Yeah, I have treated. I think so, more than 4,500. Yeah. So, I mean, you can try, but when it doesn't work anymore, then you should stop immediately. Yeah.
Look, as we sort of start to draw towards the conclusion, I guess the obvious question people will be asking is, how effective is it for people? Because being a heterogeneous group, one would expect that it wouldn't work for everyone, or it wouldn't work the same for everyone. Mm-hmm. And I know that the systolic extension training doesn't work in isolation. Mm-hmm. It will also, you work with the other more, let's say, traditional factors that influence pain, psychological factors. So you do some operant conditioning. I mean, how effective is this training?
I mean,
and can people expect this to start getting this kind of treatment from their doctor?
Mm-hmm. So the thing is, when the people suffer from the hypertension, they have the highest effects. Yeah, because this hypertension shows that the body is able to increase the blood pressure. Yeah, so, and that means when we give the 3 stimuli immediately after the systolic and diastolic peak, we can influence the blood pressure intensities, and so we can reactivate the baroreflex. Yeah, and these called of NTS reflex arcs. Yeah, so this is for sure, but it works only in combination with the psychological pain treatment. So it means when the patients learn, this is my pain network, And I can influence the pain by changing my catastrophizing thoughts to adaptive coping, changing my pain behaviors to healthy behaviors. Yeah. And we learned when patients get only the stimulation, they break up after 3 or 4 sessions. Yeah. So it means that is actually a strong suggestion that we have really a pain network. Yeah. And that means we need to influence all the components, not only the brainstem. Yeah. We need to influence the prefrontal cortex by changing our thoughts, the amygdala and other brain areas that are responsible for our emotions. Yeah. And also the somatosensory cortex, for example, by relaxation. Yeah. So, but to do just once, it's not effective. We need to do all of them, yeah, to influence all of them, because they can really interact, yeah, and they interact with each other, yeah. And so we have to come from very different sides, yeah, to be stronger than this little devil. Yeah.
Well, and it makes sense, doesn't it? I mean, the brain is complex. Why would and if you look at pain, I mean, it's not like one little part in the brain that operates for pain, right?
No.
It goes all over the place, right? It lights up like a Christmas tree.
Yeah.
So of course it makes sense that you need a multilateral approach. What about physical treatments? Have you looked at physical treatments in combination with this training?
We did.
Because there's obviously physical stressors that impact the nervous system also.
Yeah, we made bike training. Yeah. So, and combined this with the baroreflex and sensitivity training. And we saw the first time actually that physiotherapy can provoke responders. Yeah. So it means 14% of our patients could reduce their pain to 50%. Yeah. So this is the first time, because mostly physiotherapy has short-term effects. It has to be, right? I mean, it's actually the nature in us, right? So when we made sport in our childhood, it doesn't mean that we are pretty sportive also when we are older, right? So we need to make this.
We don't stay fit forever, right?
Would be nice, but no way. So we have to activate this every day. So, or at least twice a week. Yeah. So, and and that means here is the first time that this was a long-term effect. So it means 12 months after the treatment, right? So, but it's not the same effect when you would combine the baroreceptor training with psychological pain treatment and provoke the pain freedom for a long term. Yeah.
I want to just talk a little bit more about the psychological side of things, because I feel like this is one, misunderstood by the patient community, but two, I feel like it's misunderstood by the psychologists, by the treatment community, right? Yeah. And even though I think the research community has actually understood these psychological mechanisms for really quite some time. So one of the things that I've been very frustrated about is when I came up with the explanation, the program, the book, and I was doing patient advocacy. And one of the things I was talking to people about with fibromyalgia is go and see a pain psychologist.
Yeah.
And my focus was so that you seek to effect changes in your brain and you make a recovery.
Yeah.
But when they went to see a pain psychologist, they learned coping strategies and management, but all the language was geared towards just being able to live with pain better.
Yeah.
And my message was always, no, your focus should be on using these psychological techniques to get rid of the pain.
Yeah.
But it seems like there's always that the patient community didn't like this idea because it suggested the pain was like psychological, which we're saying it's not. And I felt like the community, even pain psychologists, didn't want to say that because they were afraid to make claims that they couldn't fulfill.
Yeah, yeah, and also the people are different, and many people wish to become pain-free, but then they are so under pressure that it has to be fulfilled. Yeah, and this pressure
Yes.
provokes so much stress that it's actually counterproductive, right? So, and that's why you have to find out what is the best way. I mean, one way is also there are some people or some patients who could become pain-free. Each body is different. We have to find out what is possible. Yeah.
And the best way is to try.
Yeah, just try. Mhm.
Just try.
Yeah.
But I think it's important to try with the positive expectation without the pressure. Now, one of the things in the psychological side of things, we speak about, obviously there's a range of things that can affect our pain perception. Attention, anticipation, also the meaning of the sensation, right? These are the three core ones that I'll focus on. Do you think there's any other core factors that influence pain perceptions besides those three?
Also reinforces, right? So, for example, we see in partnerships that have a high empathy level that understandably the healthy partner wants to help this ill partner, right? This is normally it's nice and it makes this kind of healthy relationship also very supportive, right? So, but what they have to learn in the treatment is that our brain doesn't interpret the support as a support. It interprets that or misinterprets that as a reward for pain. So the pain is going stronger because of the reward and is repeated and repeated and repeated. And then we have a chronic pain. So it means here we have...
And that's...
Yeah, we have to learn the intensity of the support and what kind of support. Is it a support to things that the healthy partner would have given also when the patient wouldn't be a patient? Yeah. Or is it a support that is defined by pain? Yeah. So, for example, I remember a young couple from Spain, and we spoke about this kind of pain behaviors and how she shows that and automatically and how he responds. And she said, actually, it starts already when he comes home from work and he looks at me and said, "How are you doing today?" Yeah. So, I mean, this is very friendly, right? But our brain misinterprets that, unfortunately, as how is your pain? Yeah. So, and then I asked them, and how was it before you developed the fibromyalgia? And then they thought both, and then they said, we were students, and when he came home, he said, "Do you like to order a pizza?" So, and this was completely different. It has nothing to do with pain. Yeah. So, and this was a moment when they understood how to switch, the approach and what they can do and what they can change. Yeah. So, and then she said, okay, so this is actually the idea to fake it until you make it. I said, yes, exactly. Try. Yeah. So, and so they found out really to be focused on something that has nothing to do with pain. But it's necessary to have an agreement about this, right? Otherwise, when the partner is doing this without the agreement of the patient partner, then the patient partner feels that as this is no support,
unsupported,
this is negative. Yeah. So, but when they agree with that, then they can really find completely new methods. So, for example, another example, both wanted to make a bike trip, right? So because they liked to do that before she developed the fibromyalgia. So, and then we had to find out what is the best way to do it to avoid more pain afterwards, right? So the first thing is not to think about the pain. Otherwise, when you do everything because of the pain, then you have activated your pain network already. So what can you do? We think about the the way. So what kind of trip we want to do, and what is our goal, and can we grab a coffee there to reward our trip?
Efforts.
Our efforts. So and maybe also a piece of cake. Yeah. So and so they were focused on this cake. Okay. So and then the next thing was, how can we provoke that it's a relaxed trip? Yeah. And before, it was always a situation that he, because he was faster, was the first and she followed him. Now we changed that and said she's the first and he's following her. Yeah. But his task is to say when they take a break, because this is something what she cannot not yet feel. Yeah. And so he decided to make a break, and she reported later, this is true. I didn't feel it. And it was good that he said that. Yeah. And
this is particularly insightful. Sorry to interject here, Kari, but I mean, it also helps us get around the issue that, by us, when we obviously make a decision to protect ourselves from the pain and we engage in protective behaviors, I mean, this is also unhelpful.
Yeah.
Right?
Yeah.
But at the same point, if we push beyond our barriers and create physical stress, that's also unhelpful. So it's like, this is where people think they're damned if they do and damned if they don't.
Yeah.
And so I love how they work together in the sense that he's the one who stops her from overdoing it.
Yeah.
And she doesn't act in a way like an ill person. Well, she is ill, but she doesn't have illness behavior, which contributes to the sensitization.
Yeah.
And it's really the perfect solution, is it not?
Yeah, it is. And another thing is also, mostly our fatigue and fibromyalgia patients are very, very active people, right? So they are highly motivated. That's why I like them so much. Yeah. So and have a lot of ideas what they can do and so. So and the thing is, this is something what we don't know yet. We see that the perception of the muscle tension is kind of disturbed or became disturbed during the disease. Yeah. So, for example, when I ask them, please make a strong tension, make a very light, and make a medium tension, they have really trouble to find the medium tension, right? So it means as soon as they are physical active, they go automatically in this kind of strong tension.
All out.
And this is too much. Yeah, this is just too much. And that's why the first step before we start with all the physical activation and so on, we just make the training of the muscle perception. Yeah. So, and it needs, it needs some sessions until the patient can do that. One idea, for example, is make a walk for just 1 minute as you usually walk, and count your steps. So, and your friend or partner or husband makes the same afterwards, also for just a minute, and then compare the numbers. Yeah. And then make the same with stairs and count this and then compare it. And then make a calculation of minus 20% and try to reach this new number. Yeah. And then most of our patients have this feeling, oh, this is so bad, because it seems as if somebody is holding me in the back and I cannot walk normally anymore. And this is exactly this when they feel so tensed, right? So
you're saying minus 20% in effort or tension in the muscles?
No, in numbers.
Or in the number of steps.
So when they, for example, have 110 steps, so then they should walk on this way that they have just 80. Right. Yeah. So so it means slower, right?
Yes.
So and mostly the patients make the experience that they have a higher number than the healthy spouse has.
Right.
Yeah.
Right.
And this is exactly this what when we say the devil is in the detail, right? So
Absolutely.
when they are active, then they are then the activity is too intense. So it means
Yes.
the success is possible when the intensity is going down. Yeah, and then they can do more. Yeah, like in the marathon training, right? Nobody trains the marathon. Most of the people train,
Yeah.
I don't know, 5 miles, 10 miles, or 20 miles the most. Yeah, but never the marathon. This is just only when the marathon is happening. Yeah.
Well, yeah, I mean, I often talk to people in the program about this difference between work and effort. We think, the work done is a finite amount, a fixed amount,
Yeah.
but how much effort it takes to do that can vary, and it has to do with how we engage our nervous system. You know, I can lift something, make it easy, or
Yeah.
yeah,
Yeah.
and I'm lifting the same weight, but it feels very different.
Yeah.
And inherently, the difference is the way we're engaging our nervous system, and learning how to regulate that is key. And I've actually seen some people who recover who get so good at this that they almost become superhuman.
Yeah.
One lady, she became an ultra marathon swimmer.
Yeah.
She goes in on a Monday and it comes out another country on Tuesday,
Amazing.
and she feels like she can keep running. Yes, because she's learned how to engage her nervous system. I've met many people with CFS and who've learned these abilities. So it's interesting. Before I leave, and look, I could talk to you all day, and we must finish up, but I must ask this other question. One of the typical symptoms that we have with fibromyalgia is, besides triggering of the pain, there are, for instance, times in the monthly menstrual cycles for ladies where the pain gets worse. But there's also in the daily cycle. Often we find in the late afternoon, evenings, the pain comes on and gets worse. Now, both of those, in my view, are triggered by hormonal changes and, in essence, a sensitization. And I wonder, how much have you looked into how the change in the cortisol levels during the day and connect to our experience of pain? And what is the mechanism there, do you think?
Yeah, I mean, the thing is actually very similar to the inflammatory rheumatic diseases, right? This pain is a big stressor for the body, and we could see that the cortisol level is actually dysregulated, in fibromyalgia, and that goes along with a changed pain threshold. So it means there's a clear correlation between the cortisol and the pain threshold. And when the cortisol is down, the pain threshold is down, right? And then you feel more. So, and this has also something to do with our sleep. And we see, for example, that our fibromyalgia patients have enough deep sleep phases. Interestingly, this is what we actually haven't expected, because of earlier studies. But the thing is that these deep sleep phases are in a second phase of the night instead of the first phase of the night.
I wasn't aware of this.
So, and this belongs to this whole NTS reflex arcs, of course, because this is not working so regularly anymore, and that's why the sleep is dysregulated, and that's why you have the deep sleep phases later. So, and these deep sleep phases influence the cortisol production, because in the deep sleep phase, your ACTH production is going down, and when the ACTH production is going down, then the cortisol production can go down. If it's not going down, this is what the people feel as hypophobe, that they are going crazy, then you are in this kind of mentally overactive state, and it leads to a state over the time that your kidney is just overstressed.
The adrenal glands.
English word Erschöpfung.
Exhausted.
Thank you. Yeah, it's completely exhausted.
I know future.
And this kind of exhaustion brings a situation that the kidney cannot respond adequately anymore, and so the cortisol level is going down. Yeah. Next step, pain threshold is going down. Next step, pain intensity, pain perception is going up. Next step, the sleep is disturbed, because when the pain is going up, the blood pressure is going up. Blood pressure doesn't vary anymore. So the baroreflex doesn't work anymore. The NTS doesn't work anymore. The sleep is disturbed. And so you have this devil's.
So, just in case I misunderstood here, I mean, are we saying that, is it that the actual hormone level is low, or is it the reason that the hormone level is low that is the problem? I.e., cortisol is obviously an expression of the sympathetic nervous system. So, is the issue with the pain perception, do you think that the actual hormone is low? In other words, if we were to inject someone with cortisol, would that then not produce those evening hormone? Not that you would want to do this, but would that then not produce the pain levels? Or is it simply because it reflects the fact that our sympathetic nervous system tone has changed?
Just
that the pain level.
A second. It's a little bit too quick. So the thing is, an expression of the sympathetic nervous activity is when the ACTH goes up, provoked, the cortisol goes up, and then the ACTH goes down, right? So this is this kind of negative feedback loop, and this is an expression of a healthy sympathetic response. Yeah, but when this situation goes over a long time, then we have the exhaustion, and then in the kidney. Yeah, so and then the ACTH goes up, but the kidney doesn't respond adequately anymore, and so the ACTH stays. So it means we have a higher sympathetic response over the time. Yeah. So that is the first point, and the second is when the negative feedback loop is absent, and the ACTH stays up, then we have this problem that the blood pressure is responding. So it means it goes up, but doesn't vary anymore, and then it provokes the next circle with the diminished NTS reflex arcs, and this influences the sleep, and so the patient doesn't have the opportunity to come in a deep relaxation, and so the higher ACTH production is maintained.
Right. Okay, that makes sense. So the higher ACTH production obviously stimulates the mineralocorticoids and changes the sodium potassium balance and
So and back to your question with the menstruation cycle, this is actually not yet clear what's going on there, because there was a time when we tried to find out if the sex hormones have an influence on pain. Yeah, because many women have pain, right? So but this is probably only one puzzle, in the whole picture. So I do not have so good explanations for that, unfortunately.
We still don't have all the answers. Kadi, people will ask, will they be able to benefit from systolic extinction training themselves? I mean, is this a treatment that is likely to be available around the world at some time soon?
I hope so. So it means right now we have a very expensive lab. This is not possible to transport this to hospitals or practices also. But we are working intensively on a smaller device, and hope that we can get it ready, to give it to hospitals and to the practices. And the psychological pain treatment is available, but here's also this point what you mentioned before. Our psychologists have really to learn how to treat pain patients, and to come away from this psychiatric approach and really to see this is more a training. This has nothing to do with psychopathology. Yes. This is a training how you can use your mental abilities to be stronger than the pain is.
Absolutely. Kati, thank you so much for your wonderful insights and your fascinating research, and I love how when I ask you the hard questions, you're able to come up with the answers. So it's very impressive.
Thank you.
So thanks again for coming.
Thank you for your interesting questions. This is such a nice talk. Thank you so much. Mm-hmm.
Yeah, you're welcome. Thank you.
Thanks for tuning into this episode of the podcast. We hope you felt supported by it. If you have any questions, feel free to reach out to us via cfsunravel.com, and make sure that you subscribe to the podcast on iTunes or wherever you listen to it. And you can leave a comment and a 4 or 5-star review if you feel so inclined. If you want to make sure you get your free copy of Discover Hope and get notified about all new recovery resources and interviews, including recovery interviews, subscribe to us via the website. Check out some of our other podcasts. I hope you'll join us again soon.